My name is Kaylin Gilbert, and I'll be doing a presentation on cost containment of healthcare in the United States. Healthcare in the United States is extremely expensive. The U.S. spends the most on healthcare compared to other developed nations. In 2013, the U.S. spent about 17.1% of its gross domestic product on healthcare. Although the U.S. spends the most on healthcare, it does not have the best healthcare system, and the quality of our healthcare system is below that of other developed nations. The cost of healthcare can be defined differently by consumers, providers, and the government. Consumers refer to the price of healthcare as the cost of their provider bills, health insurance premiums, prescription drug costs, and copays. Providers consider the cost as a cost of providing, delivering, and producing healthcare services and making them available to the patients and consumers. National and governmental views of cost refers to how much the nation as a whole spends on healthcare, also known as healthcare spending. Historical cost of healthcare in the United States. Healthcare spending increased at rates above 9% in the 1970s. During the 1980s, spending growth continued in the double digits but did slow down. During the 1990s, spending was brought under more control, down to a single-digit rate of growth. Healthcare spending increased so rapidly in the 1970s as a result of increased access to healthcare created by the Medicare and Medicaid programs. During the 1990s, spending was brought under more control due to control of payments and utilization through managed care. The growth rate of spending is currently increasing, but at a relatively slower pace than it was previously. In 2010, $2.59 trillion were spent on healthcare. If healthcare spending continues at the current trend, the Congressional Budget Office projects that healthcare spending will account for 25% of the gross domestic product by 2025. $2.59 trillion amounts to 17.9% of our gross domestic product. If trends are not curbed, healthcare spending can amount to 49% of the gross domestic product by 2082. Reasons for increases in healthcare spending: inflation, an imperfect market, third-party payer systems, administrative costs, our increasingly larger elderly population, technology growth and development. The healthcare market is imperfect in the United States. The forces of supply and demand are disrupted as a result of third-party insurance companies. Insurance companies prevent the consumer from actually paying the full cost of their healthcare and negotiate the prices of services. As a result of third-party involvement, consumer out-of-pocket expenses are lower than the actual cost, which can lead to more use of services. Technology is expensive to develop and involves costly research, which translates to higher healthcare costs. Growth in the elderly population has been faster than the non-elderly population since the year 1900. Elderly people consume more healthcare resources and spend more healthcare dollars than young people. As the population in the United States ages, the prevalence of chronic diseases and complex medical conditions increases, as well as further burdening the healthcare system and the cost of healthcare overall. And it strains our healthcare resources. Payment negotiation increases spending. Providers negotiate payment rates with multiple insurers and cause administrative costs to be more excessive. If consolidation of market power among providers continues, prices will continue to increase over time. Standardizing payment rates and incorporating them into the EMR will make administrative tasks more efficient and reduce spending associated with the administrative costs tied to healthcare delivery. This is an area of cost reduction that should not have a negative impact on the consumer and allow for more efficient use of already existing EMR programs. Why should we contain healthcare spending? Economic resources are limited. They're not infinite. Rising costs of premiums can put too much economic strain on businesses and lead to decreased global competition. Small businesses may not be able to afford health insurance benefits and make it harder for them to compete with the larger companies. Healthcare costs that continue to rise take up more economic resources and interfere with Americans' ability to consume other goods and services. While it is important to contain costs, it is essential that quality is improved upon. Increasing the value of healthcare delivery is extremely important. Cutting costs without considering outcomes achieved is dangerous and can lead to false savings by possibly limiting effective care. So you want to make sure that you're increasing the value of healthcare that is delivered in the United States, and to do that, you're going to increase the quality and decrease the amount of dollars spent. Strategies to contain costs. You can restrict new technology diffusion, new renovations, and new construction. You can restrict, you can put controls on prices, and you can put price controls on artificially determined prices. You can use your resource utilization groups, global budgets, diagnosis-related groups, prospective payment systems, and reimbursement formulas. And on the demand side, incentives involve cost sharing by sharing of premium costs. Deductibles and co-pays come into play. Cost measurement techniques have obscured the value of healthcare, leading to efforts of cost containment that are ineffective, incomplete, and incremental, and at times having the opposite of the intended effect. Restricting new construction, renovations, and technology diffusion are examples of supply-side control. Movement away from the fee-for-service reimbursements to pay-for-performance and reimbursements related to quality are expected to reduce spending. Utilization controls, managed care, payer-driven competition, competition among providers, and competition among insurers, and antitrust regulation are all strategies to contain costs. Government and market-based competition have been the drivers of cost control efforts in the U.S. Many attempts to control healthcare spending in the United States have only had partial or limited success. System-wide cost controls are difficult to implement in a quasi-market due to the multiple players and fragmented nature. The current fragmented payment system allows providers to shift costs from public payers to large insurers to small insurers. Research, training, and uncompensated care all need funding, and they need payment for that. Funding of research and training and uncompensated care is currently blanketed in with Medicare and Medicaid payments. These costs really should be separated out. Payments for research, training, and uncompensated care need to be transparent. Payments for research, training, and uncompensated care should be determined through negotiations and competitive bidding. Competitive bidding would allow natural market forces to influence prices. Administrative costs. Nearly $360 billion a year are spent on administrative costs in healthcare. These administrative costs account for 14% of excessive healthcare spending. The Affordable Care Act mandated that electronic transactions between health plans and providers must be standardized. Standardization allows for more efficient use and may contribute to lower costs. Public and private payers should use a standardized credentialing system and not have multiple systems in place. The integration of clinical and administrative functions into the EMR can increase efficiency and reduce administrative costs. Price transparency. Prices for the exact same services in the same geographic area can vary considerably. If patients or consumers had access to price information before treatment, they could plan ahead and select providers that offer lower costs, especially if the consumer has to pay the difference in cost. They're going to choose the lower cost healthcare option. Prices and costs should be made readily and easily available to consumers so they can make more informed decisions. This also helps consumers to feel more in control of their health care. Self-regulation. So a self-regulation model would allow public and private payers to negotiate payment rates with providers. These rates would be binding on all payers and providers in a state or a geographic region. Privately negotiated payer rates must adhere to global spending targets for both public and private payers in a state. And then after transition to self-regulation, the target should limit growth in healthcare spending per capita to the average growth in wages. Spending growth tied to average growth in wages can prevent wage stagnation. So in essence, payments need to be more similar among private and public payers, but you need to be able to account for inflation in the future. Value-based purchasing provides financial incentives to increase healthcare quality and decreases cost. Value-based purchasing uses financial incentives to reward healthcare services that are cost-efficient and high quality. Early evidence about how effective value-based purchasing has been limited, but is promising. Spending growth is slowing in the United States. Using the HCSA to measure spending, it can be determined that spending growth in healthcare from 2011 to 2012 was comparable to the average growth rate during the recession period from 2005 to 2010. During the recession period, the growth in healthcare spending was very low. In 2011 to 2012 demonstrated the slow growth rates and cost per case since 2000. So things were slowing down in 2011 to 2012. The Affordable Care Act. In 2010, Medicare reduced its provider reimbursements to providers and hospitals, which contributed to decreasing cost per case across all illnesses and injuries. Free preventative care was implemented in 2010 and caused an increase in the number of individuals obtaining preventative services. Healthcare spending increased to 5.3% in 2014, up from the 2.9% growth in 2013. This increase is attributed to the ACA. The ACA tries to reduce costs mainly by reducing Medicare payments to providers. The increase in costs associated with preventative care was expected as access has increased. The goal of the ACA is to reduce costs down the line by increasing access to preventative care and services and ensuring that high-quality primary care services are in place to prevent more expensive health issues later. The Affordable Care Act made it possible for more competition among health insurance plans. Not the perfect solution, as there have been increases in premium costs, which have added additional expenses, mostly to employers who offer insurance to their employees. Accountable care organizations are comprised of healthcare providers that take on financial risk associated with the total cost of care delivered to a defined population. Accountable care aims to encourage and facilitate improvements in the delivery of care through payment reform. Again, the emphasis is on value and outcomes, not like individual services provided. Accountable care organizations continue to grow. Policies around accountable care organizations are evolving and changing. There's a possibility for population level payments with the ACOs. So you're looking at the whole community health versus an individual outcomes. Cost containment. It is essential that spending on healthcare in the United States is reduced while the quality and value of healthcare delivery increases. The perfect solution has yet to be determined, but the U.S. is moving in the right direction on reducing spending. References, and thank you very much.